Hello to Barcelona in Spain, and welcome to this e-cancer debate educational program. Today we have a great honor to have a great panel of experts in the treatment of urothelial carcinoma, and they're going to introduce themselves.
So good morning, my name is Eva Comperat. I'm a uropathologist in France, working for the Sorbonne University, and I'm very pleased to be here.
Dr. Loriot, I'm a medical oncologist, and I'm working at Gustave Roussy in Paris, and I'm especially focusing on bladder cancer.
Hello, I'm Maria De Santis. I'm a medical oncologist based in Berlin in Germany and working at the Charité Medical Hospital.
And I'm Michiel van der Heijden. I'm a medical oncologist at the Netherlands Cancer Institute in Amsterdam, the Netherlands, and I also focus on the treatment of bladder cancer. I'm looking forward to a great discussion here.
Thank you all of you for being here. I'm Dr. Javier Puente, and I'm a medical oncologist at the Hospital Clinico San Carlos in Madrid in Spain. And the objective today is try to talk a little bit about the recent advances that we have today and that have been presented during this ESMO in the treatment landscape of urothelial carcinoma. So we can start, for example, with the metastatic setting. We have several abstracts that have been presented this morning in Barcelona with new drugs. For example, first of all, we can talk about the sacituzumab, these new drugs, anti-TRAP2. How do you see these results, Maria, in this context?
Well, I think that sacituzumab being an antibody drug conjugate is one of the most interesting developments for also urothelial cancer recently. So the first data we have seen with the antibody drug conjugates was enfortumab vedotin, but today new data of the sacituzumab govitecan was presented, and I think the important part here is that it has different properties compared to the others concerning the payload, the chemotherapy. So those ADCs have an antibody that is targeting an antigen. Those are different. Then they have a linker, but then a payload. And most of the other ADCs have the MMAE as a payload, but the sacituzumab has a payload that is different. And it delivers irinotecan, so topoisomerase 2 to the cell, which is much more potent than the irinotecan, and that's why it is tolerable, because it's more it would be more toxic. And this is to me the big difference, and it has been shown today that it allows a high response rate in heavily pretreated patients. And they also showed one patient, and I thought it pretty interesting, that patient was pretreated with 4 different drugs, including enfortumab vedotin, another ADC, and still had a tumor reduction of more than 70%. And I think this is the really interesting difference here. With the sacituzumab.
And what about the toxicity? Because we have observed a very high level of neutropenia with these drugs.
Well, the conclusion of the authors was that the toxicity is manageable, which certainly is true. We have been dealing with neutropenia and neutropenic fever for many, many years, so we are used to dealing with that. But of course, there is quite a high neutropenic rate, and we need to consider using GCSF, etc. But I think the neutropenia rate is tolerable. I would be a little bit more concerned about patients with diabetes, because we have hyperglycemia or the neuropathy rate. So this can be an issue for patients with comorbidities, for example.
Looking forward, maybe it could be a problem for the combination of these drugs with another drugs in the future, because this toxicity could affect it for the combination of these drugs to other?
Well, it depends on the combination. So combining, for example, with immunotherapy should be okay, because there should not be overlapping toxicity. But this was also tried out in the first-line setting, and we saw the data after enfortumab vedotin with pembrolizumab, and here we actually did not see additional toxicity or enhanced toxicity of the combination, but just the toxicity we would expect from enfortumab vedotin by itself in the pembro.
And this trial raised a very exciting new question, I guess, in terms of precision medicine with the ADC. It's pretty new, actually. We know how we can select patients with target therapy, EGFR inhibitors, BRAF inhibitors. For ADC, it's a new field, actually. If we have both drugs, maybe in coming years, phase 3 trial, positive phase 3 trial, how we can select patient for enfortumab, sacituzumab. So this was a question of maybe the spatial heterogeneity within the tumor and how we can correlate this to the activity of one drug, enfortumab or sacituzumab.
It's a good point.
Very new
It's a good point, Yohann. However, we have the recent data of the BSky trial. The BSky trial is a very innovative trial trying to incorporate this biomarker in the decision of the treatment, and the results is not very encouraged. It's very little disappointing.
Yeah, it's disappointed. I think everybody in the audience was quite disappointed by the trial. It was a very innovative trial, and it required a huge effort to conduct this trial for sure. But I think it was a first generation, once again, of precision medicine program, because based on the DNA. And now we know in oncology that the cancer is very complex, and we should probably control many parameters, say the microenvironment, the clonal evolution, and the spatial longitudinal heterogeneity. So it's disappointed, but we have to move forward and maybe integrate more factor if we want to conduct such trials.
That's definitely, because I think that we have to involve more our pathologists in this driving decisions in the future, maybe. Obviously, today we have only what is the kind of tumor that they have, maybe the grade of differentiations, but they don't have any biomarker today available in this disease.
Well, this is a little bit the problem when you look as a classical pathologist on what is going on, for example, in bladder, especially in bladder. The classical pathology is a little bit disarmed, I would say. We have had all these things with PD-L1 testing and so on, which was not really extremely conclusive in my opinion, and now it's going forwards to more and more towards molecular biology. On the other hand, I would like to underline that we still do not have any international validated panels. We're extremely tissue dependent, and we don't know what kind of tissue we really want to test. We want to test the primary, the lymph node metastasis, the distant metastasis. Do you want to make liquid biopsy, which is clearly not pathology anymore? So I think we really have to work hand in hand with geneticians and NGS and all these kind of things which are not available in a normal pathology lab, which must be clear too.
And in this metastatic setting, Michael, we have recent data from a long follow-up in the MIGO 211. Could you comment that?
Yeah, absolutely. So first of all, I want to also emphasize, going back on the previous discussion, that Yohann is describing a problem that I think is a fantastic problem to have. It's only a few years ago that we only had platinum-based chemotherapy, and now we have checkpoint inhibition, and actually a lot of choices in the third line with response rates are at 40%. This is a tremendous luxury. We are not there yet, clearly, but it's a tremendous luxury to have this kind of choice between different new drugs, the antibody drug conjugates, but also FGFR inhibitors. But indeed, we for the second line, of course, there were checkpoint inhibition is the development of already a few years ago by now, and one of these randomized study was with atezolizumab, and what we did is we followed these patients and did another overall survival analysis to get some landmark analyses on overall survival and durability of response, basically. And what we saw there is that actually where the curves took a while to diverge, they actually seem to, at more or less the time of the primary analysis, diverge, and then that difference was maintained. So at the 2-year landmark OS point, there was a 10% difference in overall survival between the checkpoint arm, in this case atezolizumab, and the chemotherapy arm.
So it's clear that there is a segment of patients that they are very, very sensitive to this immunotherapy and continue alive for a long period of time. And in the first line, moving to the first line, today we have the presentations of the combinations of enfortumab vedotin plus pembrolizumab, the results, I think that is very impressive for all of us. Could you comment this trial?
Yeah, it was a phase 1 trial, so combining enfortumab vedotin and pembrolizumab in first line in mainly cis-ineligible patients. We know that this patient has a poor prognosis. Chemotherapy with carbogem is not a good option because the median overall survival is still very poor. So we're trying to find any way to improve the outcome of this patient. And this data, preliminary data on only 45 patients, show a striking response rate of 70%. So the safety also, it's acceptable. The combining seems to be feasible. The point in that we have to be sure that the duration of response and so PFS and overall survival are impacted by the combination. So that's the priority of this kind of trial is just to know if we can have a long-term outcome with such combination. I think it's an important question regarding the data we will have during ESMO with the MVigor 130 as well. So we have a press release stating that chemotherapy plus atezolizumab improve PFS, maybe not overall survival, but I think we have to discuss and how we can be sure that the combinations impact the outcome of the patient. So overall response rate is a preliminary result, but we have to follow with this trial and just to be sure that we have a very good outcome in terms of overall survival.
Maria?
Yeah, so I think for the cisplatin ineligible patients in the first line, there is a clear unmet need, and currently we use immunotherapy in the PD-L1 positive patients. But the data still is not that great, but with the combination what we saw today, the data is really very intriguing. We were really fascinated by what we saw with regards to a reduction in tumor size by 90%, etc. But what I wanted to say is that with that combination, if this data are translated in PFS and OS benefit, it might well be that one day we end up with a non-platinum containing first-line treatment for those patients. Because in the MVigor 130, it is again chemotherapy with platinum plus immunotherapy. But it would be kind of nice maybe to have a non-platinum combination ones that really works and maybe is better than what we have been using for the last 30 years.
However, many oncologists are currently recruiting patients in two trials with enfortumab, the EV201 and the 301. The first trial is after a failure of immunotherapy, and the second is after chemo and immunotherapy. But today, with these results, I don't know what could be the next step in the development of this drug. It's currently focusing the second or third line, or we are putting these drugs in the first line setting?
I think there is two ways. The first probably is the neoadjuvant setting, and especially for the patients who are not fit for neoadjuvant chemotherapy. We know that it's around 40-50% of the patients. And as Maria said, we have now maybe a platinum-free regimen. So maybe this combination could be very useful in this patient. And given the response we have, 30% of complete response and 70% of overall response rate. And if possible, if the safety is acceptable, maybe we have to give the patient a big cocktail. Chemotherapy, EV, checkpoint inhibitors, and maybe it could be impactful as well.
Yeah. Maybe we need the help for pathologists or biologists, because when you see the data for the MVigor 130, there's a lot of patients that have been treated with carboplatin, even when they are defined like cisplatin eligible. So at the end, we have a lot of variability in the treatment of those patients in the first line setting. So we need something to select properly patients in this setting.
I completely agree, but you know, the history with biomarkers is a very long history. We really try very hard, and we have tried with urine biomarkers, for example. Now I think, for example, if you have a patient who has been treated in first line and who will escape, it might be interesting afterwards to test as well what remains from the primary and maybe the lymph nodes too, so to see whether there's any discordance, whether there's tumor heterogeneity and whatever, and try to adapt. But this is a very wild field which is completely underexplored at the very moment.
It's even much more complex with the combination, because we saw that Pembro and EV, PD-L1 status, is not useful anymore.
That's it.
So for the future, maybe you will still stay with us.
Thank
but,
you. Thank you.
And what about the mutation of fibroblast growth factor receptor? Because this is something that we have to take into account.
Upcoming, yes, but I think it's not interesting for every tumor. It's probably very interesting for the luminal tumors, especially for the papillary luminal tumors, which we might be able to discern already a little bit in histology, but this will not be the only tool. So of course there will still be a very big room for sequencing, but I think FGFR3 is not the only one. It's a minor part of the tumors. There are all the basal squamous tumors, for example, where we really have to find also the perfect target probably. And for example, also the luminal non-specified or unstable, which are quite tricky tumors and which are not able to be distinguished under the microscope, for example.
Any comment more from the first line? No? So we can move to another X scenario. We have data in the neoadjuvant setting with the Nabucco trial. Michiel, could you comment something about that?
Yeah, so we're very excited to present our first data of the Nabucco trial, which is a trial which investigates the combination of ipilimumab and nivolumab in stage 3 localized bladder cancer, or at least T3, T4 and nodal positives. So we've previously seen monotherapy checkpoint inhibition with pembrolizumab and atezolizumab, mainly in T2 and T3 tumors, so slightly smaller tumors, though still, tumors with a high risk of recurrence. So we tested Ipi-Nivo in a very high-risk group, and we were really struck by what we found, that we had 46% of patients in this population had a complete remission pathologically, and 58% who had non-invasive disease. So these patients had, so these additional 12% of patients had, for example, small focus of CIS or TA, so that's a stage that is generally seen as cured by this surgery. Moreover, we saw multiple patients who had still very clear responses in their tumor, but had more of a mixed response or a partial response, or near complete remission, or still some tumor foci left. So I think this is a very exciting result to see such extreme responses. Moreover, the treatment was feasible to give to patients preoperatively, so we managed to do surgery in all of these patients. 96% of them, so all but one, in 12 weeks from start of treatment, and one patient had a delay of 4 weeks because of an immune toxicity.
So do you think that this difference between the Abacus Pure and Nabucco trial that could help us to select properly in the future? Because obviously we have 3 trials made in the same setting with different drugs. Any idea about how can we select that?
Well, of course, this is, these trials are gold mines for translational research. So we have tissue before treatment and tissue from the cystectomy. So, of course, it's going to be very important to try to see if we can select the patients that will respond. In our cohort, we found an association with PD-L1. I think in the other cohorts that was found as well. But there's a lot more to investigate, and I think it's going to be, of course, very important what patients should I give this type of treatment, or what patients needs chemo, and maybe there's a group still that could use enfortumab vedotin or go directly to surgery. So I hope there will be a future where the pathologist has a very prominent role, and we know what to give our patients.
We are praying a lot for that.
Yeah, no, but it has become extremely complex when you look, for example, also between epithelium and the mesenchyme stroma. There are so many responses. I mean, there are so many pists, and there are so many things where you say this could be exciting and this could be exciting, but there are so many interactions which you really completely underestimate. And for us, it has, I would say, for the moment, the classical pathology has become clearly impossible to do everything you need in oncology. And of course we have to rely on molecular biology, clearly. But even this will, for the moment, not be enough, probably. It will take us some time to sort it out.
And finally, we have 2 minutes for comment something about the non-muscle invasive disease. I think that is a great part of this disease, because obviously most of these patients will be relapsed, and after that we have to suffer a cystectomy. So how can you think about these new drugs that they are being investigated in this setting? How do you see these results with Pembro or with another drugs in this setting?
I think Pembro is quite interesting. There is a very huge trial actually ongoing in France, which is called Alban, which is with aceto against BCG in high-grade tumors. We do not have the results yet, but I think that will be quite interesting too. And I think especially immune checkpoint inhibitors will be something quite interesting because we will be short of BCG in the upcoming years, and therefore we have to find other ways to treat these patients, especially the T1 tumors, which are quite tricky.
Johann, you have?
Yeah, yes, I do agree. The preliminary data we have in setting are pretty encouraging. It's still immature, but it's still encouraging, and there's many different phase 2 trial albums in France, Potomac. So investigating durvalumab with BCG. So it takes a long time for sure to get the data, but I think if we want to impact the disease overall in bladder cancer, we should move earlier in non-muscle invasive bladder cancer for sure. So we should investigate this new drug earlier.
That's it, because obviously we have a spectrum of diseases from low grade to high grade with high risk of relapse. And those patients, if you can avoid this great surgery, so I think this is great news for us. No? So any comment?
I think also carcinoma in situ, especially in non-muscle invasive tumors, plays a very important role. And I think it's not the same history if you have a TA high-grade tumor with carcinoma in situ or without. Same history with T1, of course, because I think that's really completely underestimated. But clustering has shown that these are really distinct diseases with or without carcinoma in situ.
Any final comment that you want?
I think it's very exciting times for bladder cancer with lots of new developments, and there's still a lot of work to do, but it's a very exciting time to be involved in bladder cancer treatment.
It's not an orphan disease anymore.
No.
Maria?
Yeah, so I think we are all excited about the ADCs and more chemotherapy, but I'm especially excited about the precision medicine that actually was introduced for bladder cancer this year. FGFR inhibitor with erdafitinib, 40% response rate in marker selected in FGFR 2 and 3 mutated patients. And Yohann, you are the first author of the New England Journal of Medicine paper. Maybe you want to say one word on that, because for me this is really big news for bladder cancer.
Yeah, for sure, it's the first target therapy we have in the field, so it's very excited. And now we have to maybe to learn from lung cancer and melanoma, trying to follow this model and to improve how we are doing precision medicine program in bladder cancer.
That's it. So thank you, Michiel, Maria, Yohann, Eva. Thank you for joining us, and thank you all of you for joining us in this A Cancer Debate Educational Initiative. Thank you so much.